I have the pleasure of introducing Dr. Lulu Zhao. Dr. Zhao is an assistant professor at Case Western University School of Medicine, who is board certified in both excuse me, obstetrics and gynecology and addiction medicine. Her clinical and scholarly work centers on the intersection between mental health, women's health, and social determinants of health. Dr. Zhao completed her residency in obstetrics and gynecology at University Hospitals Cleveland Medical Center and a women's mental health fellowship at the University of Michigan. She helped launch the reproductive psychiatry service line at University Hospitals and is the director of Rise Moms, a specialty clinic serving pregnant and postpartum women with substance use disorders. Clients within Rise Moms are able to receive simultaneous perinatal and addiction care, as well as guidance from experienced social workers on navigating the treatment and child welfare spaces in Northeast Ohio. A major goal of Rise is to maintain the safe union of the mother-baby dyad and to propose, and to this purpose, Rise engages in advocacy work within educational, medical, and legal spaces. Thank you, Dr. Zhao, for joining us today.
Thank you so much for that introduction, Dr. Curry, and I'm very excited to be here with you guys today. I am going to go through my talk, and then hopefully we will have some discussion at the end of the presentation, because I'm also very curious to hear what things are like in your state of Arizona. The topic of today's talk is thinking critically about child welfare referrals for parents with substance use disorders. I don't have any disclosures. And our goals for the talk today are to appraise your understanding of how the medical system interacts with the child welfare system, and to identify areas where implicit bias can create unintended negative outcomes for parents, and then to propose changes to practice that can improve these outcomes for patients and their families. I'd like to start our talk today with an amalgamation of a story. This is sort of things that my patients have personally experienced, and their experiences have really changed how I thought about the child welfare system. So this is Shamir. Shamir is a 26-year-old woman who follows with you for anxiety and ADD. Her ADD is pretty well controlled on extended release Adderall. She has a past history of benzodiazepine misuse and primarily relies on psychotherapy for management of her anxiety. She also uses recreational marijuana about 3 times a week, mostly on the weekends. She reports that it does help with her anxiety. She has a steady job as a call center representative, and she is in a supportive relationship with her boyfriend, Richard, who also uses recreational marijuana. As part of your treatment monitoring with Shamir, you collect urine drug assays during her visits with you, approximately every 3 months or so. They've always been appropriate. At your last visit, Shamir shares with you that she is unexpectedly pregnant, having believed that she was not able to get pregnant due to a diagnosis of PCOS. She's actually pretty far along, about 26 weeks, as she has irregular periods and therefore didn't recognize she was pregnant until the late 2nd trimester. And then she kind of ran into issues with getting a new OB appointment because of availability regionally. So her next appointment with her OB is actually tomorrow. It's her first appointment. So her main question for you today is it okay to stay on her Adderall for her pregnancy? You know, she stopped at first, but she felt symptomatic, so she's resumed. And that's her main concern today. So some questions for you guys to think about. How does Shamir's pregnancy influence your treatment and management decisions? Do you bring up her marijuana use, even though she didn't mention it to you? Is there an informed consent process at your institution for doing urine drug screening? And does that assay test for THC? And then do you know if in your state it's considered child abuse to use THC during pregnancy? Moving on with Shamir's story. After discussion with you, Shamir does decide to stop her marijuana use and then to continue her Adderall at the lowest effective dose. She goes into labor on her own at 41 weeks and got an epidural shortly after arrival to the hospital and has a successful vaginal delivery. The baby does go to the NICU for respiratory distress related to meconium aspiration. In the NICU, Shamir does not cope well with the stress of the baby's medical illness, and she is often irritable with the nurses or takes long breaks outside to relieve her anxiety. One of the NICU nurses documents that Shamir seems detached from the child due to her absences and perhaps lacks skills to parent successfully. Due to this, and because of Shamir's documented history of benzodiazepine misuse and cannabis use, Peds requests a urine drug screen sent from the maternal urine. The only sample available is the one collected post-delivery, and the OBGYN resident sends it off. This urine comes back positive for fentanyl and amphetamines, and social work places a DCFS referral. Questions for you guys to think about. Are there steps that could have been taken to avoid this turn of events? How would you have interpreted Shamir's urine drug screen? And how much leeway does your hospital provide in reporting once a positive biologic assay is obtained? Shamir's first DCFS worker has a positive and compassionate attitude towards the couple. She reaches out to the OB team about the urine drug results and is satisfied that it is a result of prescribed use. Shamir's case is found to be unsubstantiated and no case is opened. At 4 weeks postpartum, Shamir returns to your office for follow-up and describes significant difficulties with colic and breastfeeding and generally feeling inept as a first-time mom. You diagnose her with worsening anxiety, and she consents to a trial of an SSRI after some initial hesitation, as her sister had gained a lot of weight on SSRIs in the past. She has started on sertraline 100 milligrams daily and diphenhydramine for insomnia. Her mood does improve, and she starts back at work at 8 weeks postpartum. At 3 months postpartum, the baby rolls off the couch while under Richard's watch. The baby cries loudly for a few minutes, but otherwise seems fine. Angry at Richard and scared for the baby, Shamir insists that they bring the baby to the emergency room for evaluation. At the ED, the physical exam is reassuring, but at Shamir's insistence, an x ray is performed. The x ray shows a right sided skull fracture. Both Shamir and Richard are requested to submit a urine drug screen by the ED physicians. Richard's screen shows THC, and Shamir's shows THC, amphetamines, and benzodiazepines. Questions for you to ponder again. Is it common at your institution to order urine drug screens for pediatric injuries? How would you interpret these urine drug screens? And do you think parental marijuana use contributed to the baby's skull fracture? Due to concerns that parental drug use may have contributed to the baby's injuries, a DCFS case is again a DCFS referral is again made. With a high turnover at DCFS, Shamir is assigned a new caseworker who has no pre-existing rapport with her. This worker finds the allegations of abuse substantiated due to the positive drug screens and the baby's injuries. During investigation, they find that Shamir has a history of substance misuse, that Richard is continuing to use marijuana recreationally, and that the housing conditions of their rental are poor as the windows are painted shut and the water tank is broken. A case plan is made. The parents are told to fix the housing issues or find new housing. Both parents are mandated to enter IOP for substance use disorders and to submit to twice weekly random drug screens with the expectation to be negative for any and all substances. They are also mandated to attend safe parenting classes. A safety plan is also created in which Shamir's grandmother must be with the baby at all times. They are told that failure to comply with the case plan can result in child removal. Final questions. How might case plans disrupt parenting and work-life obligations? And how might case plans disrupt family dynamics? And what do you think the prognosis is for this family? Okay. So I'll let you guys think about that case. And like I said, all the things that happened in that case happened to actual patients that I've taken care of. So a little bit of background. Over 21 million children live with a parent who has misused substances in the past year. Overall, about 2 million children, or about 2% of children, have a parent with a substance use disorder and live with them. And 1 in 8 children live in households where at least somebody has a substance use disorder. Mirroring kind of statistics in the general population, substance use in pregnancy has increased. About 8% of pregnant women use illicit drugs during their pregnancy, with marijuana driving a lot of that illicit use. Um, Alcohol it's decreased a little bit over time, but still about 10% of pregnant individuals use alcohol within the last month. And basically every organization out there, ACOG, AAP, March of Dimes, CDC, all discourage the use of substances during pregnancy. There are some adverse consequences related to using substances in pregnancy. So some very common obstetrical adverse sequelae include low birth weight, preterm birth, and placental dysfunction. Also, babies can experience withdrawal symptoms at the time of delivery. Now, when we think about harms caused by substances, it is important to realize that when you take a deep dive into the studies, some of these associations do disappear once you account for confounders. And the degree of harm caused by substances varies a lot depending on individual circumstances. That being said, continued drug use certainly has some risks to children outside of the womb as well. They do tend to have more exposure to trauma and violence. They may have chaotic and unpredictable home lives. There is an increased risk for child maltreatment when the parents are using substances. And there can be subtle and persistent neurodevelopmental changes after in utero exposure that usually become more apparent as children reach school age. And then finally, children who are raised in substance using parents are at increased risk of using substances themselves. No one is arguing that using illicit drugs during pregnancy is good. But I think the other question we should ask ourselves is, could it be that some of our responses are causing their own problems? There are several pieces of federal legislation that influences how we manage potential child abuse in this country. The first is CAPTA. So CAPTA is the Child Abuse Prevention and Treatment Act. This was first passed in 1974, and it kind of created the infrastructure for how systems should respond to child abuse. The funding that goes to CAPTA, the majority of it kind of goes towards foster care placements and funding foster parents. But some of it does also fund community-based services that kind of decrease the need to put children into foster care. In 2016, CAPTA was amended by the passage of CARA, or the Comprehensive Addiction and Recovery Act. CARA was passed as a response to the opioid epidemic. It created a relationship between child welfare, medical personnel, and mental health agencies in the community. And it required that for any infants that were 1 year of age or younger that were prenatally exposed or demonstrating symptoms of withdrawal, to have a plan of safe care. And the plan of safe care usually it can be pretty comprehensive, but it requires that risk factors are addressed and that basic safety needs are met. Adding to CAPTA and CARA are individual state laws and policies and statutes. So 23 states and the District of Columbia consider substance use during pregnancy to be child abuse under child welfare statutes. and 3 states consider it grounds for civil commitment. Meanwhile, 25 states, including and the District of Columbia, require health professionals to report suspected prenatal drug use. This I pulled from your government, your state website, because I wasn't familiar with Arizona's policies. And I just highlighted some parts that I thought were interesting. So, at least per the policy, it says that the department shall investigate all reports alleging that a newborn infant has been prenatally exposed to alcohol or a controlled legal or illegal substance. Seems pretty broad. Um, and it says any infant who is prenatally exposed or is demonstrating withdrawal symptoms resulting from controlled substances is considered vulnerable to abuse or neglect. And so, I think and we have very similar guidelines here in the state of Ohio. I think, this is DCFS guidance, and it oftentimes is different than how I think a medical person would consider their assessment of risk. But because of the typically collegial relationship between DCFS and hospital systems, medical providers often perceive very little leeway as to when they have to report. Also, sometimes reporting requirements can be contrary to what seems common sense by patients and providers. So, for example, and please correct me if I'm wrong, but I believe that your state legalized medical cannabis in 2010 and recreational cannabis in 2020. And Ohio is very similar. We had medical cannabis that was legalized several years ago, and we just passed a ballot measure to legalize recreational cannabis. And so, a question I'm getting a lot now in the state of Ohio is, is it legal? Is it okay now to use marijuana during pregnancy because it's legal for adult use? And, do I have to worry about being reported? And so, it would seem, I think a lot of patients would believe that it's no longer reportable because it's a legal substance now. But of course, DCF guidance is different from that. Their stance is sort of business as usual. So, and their argument is just like alcohol is legal, we can still investigate parents who are using alcohol during pregnancy. So they still want us to report parents who are using marijuana during pregnancy, even if we don't believe it to be harmful. And so, I think it just points out that a lot of times there can be these inconsistencies or incongruencies between, the legal and social work perspective and the medical perspective. And so, kind of just looking at your state's website, it says that it is okay to use marijuana during pregnancy, but it can only be medical marijuana. And I do wonder if this is how it's always been, or this was added or amended on the website after the Arizona Supreme Court ruled in 2019 that you shouldn't be adding people to the DCFS registry for using medicinal cannabis. But I will just say, like, most of my patients, now that marijuana is legalized in Ohio, don't plan to pay the money to get a medical marijuana card anymore. So if the policy for us is going to be the same as for you guys, they would still be reported. Now, not surprisingly, parental substance use is a contributing factor in 50 to almost 80% of child welfare referrals. And for infants referred for in utero substance exposure, about 83% will be screened in for investigation. And medical personnel are the third most common source of referrals behind law enforcement and educational personnel. Children under the age of 1 now represent the largest age group of any children in the child welfare system. And this statistic is driven by an increase in infants exposed to drugs in utero. Why does removal happen so often? Why are there so many young children in the child welfare system? Well, it's because The child welfare system can be really complex. The system is meant to protect children, but there are many challenges for it working that way in reality. First, the process can vary significantly from state to state, even county to county or city to city. Children can be removed from homes with the lowest legal standard of evidence. You only have to have reasonable standards or a risk of immediate harm. And these are not things that have to be strictly substantiated. For reunification, parents must often complete an arduous and somewhat cookie cutter case plan and submit to supervised visits. Mm, mm. Parents legally only have 1 to 2 years to complete the case plan before their parental rights are permanently terminated, meaning they will have no rights to their children at all, ever. And then, unfortunately, most funding provided by the federal government for child welfare statutes doesn't really address the underlying causes of children being removed from families, such as poverty, unstable housing, etc. Now, I don't want to give the impression that DCFS is the bad guy. They're not bad guys. And I work with quite a few people in the judicial system and at DCFS. They are, from their perspective, seeing terrible outcomes from parents who were not properly investigated, whose children died. And these are horrific, traumatizing outcomes, of which they, of course, want to avoid at all costs. But I think what's important to realize as a medical provider is that DCFS workers and magistrates, their training and their experiences are different from ours. And so a patient who seems to be doing well by our standards can be seen as failing by DCFS. And so it really behooves us to be more involved and more advocates for these patients because the old adage, which I was taught as a resident to refer to DCFS and they'll do the right thing and figure it out, unfortunately doesn't always happen. What are the consequences of policies that make referral and investigation easy, but actual help hard? So this is a bill that was introduced in your legislature that didn't pass, but I think it is very similar to a lot of bills that I see related to parental drug use. So House Bill 2530 would have required DCFS involvement upon communication of a prenatally exposed pregnancy. And the idea was that once that happened, DCS would tell women about how to access health services, but not required to do too much beyond that, and that medical providers had to refer women for treatment. It was passed by the House and the Senate, vetoed by your Democratic governor. And I think this type of bill often reflects some of the weaknesses in popular notions of how to help patients with substance use disorder. They're very much focused on reporting and focusing on medical treatment without thinking about the reality of what help is available to families in our country. Lack of geographically accessible drug treatment programs, insurance barriers, stigma, inability to accommodate mother-baby dyads, and lots of other barriers obstruct effective implementation of, even state laws that want to prioritize treatment for pregnant women with substance use disorders. Typically, when you refer a patient to DCFS, DCFS is going to mandate treatment, and it takes at least 30 days usually before patients get any kind of treatment, if at all. And in 2021, they did some research looking at data from children who were sent to foster care, and only 2/3 of the families who were referred to DCFS for in utero substance exposure were referred to appropriate services. So here you have an agency asking patients to accomplish an outcome without always giving them the goals, the tools to achieve those goals. This is information from the National Survey of Substance Abuse Treatment Services, or NSATS. It is an annual survey of facilities providing substance use treatment, and it's conducted by SAMHSA. So this is just some NSATS data from Arizona that I pulled up. So it shows that, much like other places in the country, almost half of the treatment facilities in Arizona are private or profit. About 30% do not accept Medicaid, which is the predominant health insurance of low-income pregnant women. Only about 25% of treatment facilities accept pregnant patients. And only 2% offer beds for clients' children, which, as you can imagine, a lot of these women have children and no other supports to help care for their children. So they can't enter a facility if their children can't come with them. And then less than 50% of facilities offer pharmacotherapy for substance use disorders as part of their services. And I don't know how it is in Arizona, but there's also, at least in Ohio, a lot of facilities that still do not accept women or clients who are on MOUD into their facilities, which is totally disparate for what we are taught as addiction medicine providers. The thought of DCFS for involvement is very daunting for women, and I think it is a weakness of legislation that requires or mandates the involvement of DCFS in the treatment process. You know, women are oftentimes not naive about the weaknesses in the DCFS system, and if they think they're going to get involved, they can shy away from seeking treatment. As current data stands, states with kind of punitive policies towards pregnant drug-using women tend to have the worst outcomes. So despite the fact that these policies are meant to be a bit of a carrot and a stick for women to get into treatment, what really happens, at least on the data side, is that these women tend to avoid prenatal care. They are oftentimes not disclosing accurate medical history to their providers. And they also they're not seeking addiction treatment because, they don't want to have that in the record. And this results in worse outcomes for both mothers and babies. Because reunification is often contingent on the parent's sobriety, states where women are deterred from seeking care see lower rates of reunification of the mother-baby dyad. What about, what happens when the woman gets referred? So when substances are involved, parents tend to face 3 times the rate of removal, and there's a higher rate of permanent removal as well. There's also a longer number of days when the child tends to spend in foster care placement. Children who are removed from the parents exhibit a variety of adverse outcomes, even if they are safe. They tend to have insecure and disorganized attachments and more externalizing, internalizing behaviors. It can be a traumatic loss for them, especially if they are going from unfamiliar environment to unfamiliar environment. There can be a negative social perception of children who are in foster care. And then, at reunification, they can experience a lot of ambivalence. It's also important to realize that children oftentimes enter the foster care system more than once. And there is a higher rate of foster care reentry when parental substance use is pregnant. So all these negative outcomes, they tend to happen more than once. What about on the mom? Removal is a profoundly traumatic event for parents, and it is a long-lasting trauma. And I can definitely speak from my experience with patients that this is very true. The process of removal creates mistrust, and it oftentimes, creates a lack of motivation to do the work because women just feel really discouraged, like there's nothing they can do to beat the system. It tends to increase temporarily the use of drugs and alcohol, and have people engage less with treatment services. There is a lack of self-care after children are removed, and an onset of depression, anxiety, PTSD. I've had women who were stable in sobriety for years, really, from a medical standpoint, doing very well, who had the children removed for reasons like, they lived with a partner in the home and the partner was not sober, even though the woman was the primary caretaker and perfectly competent. And I have seen those women relapse and do very poorly in their health. This is a study looking at child removal and short interval births among individuals with prenatal substance use. This was just released last month from our major academic journal, Obstetrics and Gynecology. I think some people, I don't think most medical providers believe this, but some people believe that removal is such a harsh outcome that people would be deterred from the same thing happening again. But in fact, mother in this study, and this has been shown in older studies too, mothers whose children were removed are twice as likely to be pregnant again within 6 months and 3 times as likely to have another substance-exposed birth. And finally, I don't think any talk about the American healthcare system would be complete without talking about race. There is significant racial disproportionality in the foster care population, meaning the percentages of children of minority races definitely are larger than they should be, given the percentages of those races within the American population. So, Native and African American families tend to suffer the worst outcomes in child welfare investigations. And reunification for young children is substantially less likely for these same populations. And that makes sense, right? Because hundreds of years of systemic racism have kept these families in poverty with limited resources. And poverty, in turn, prevents parents from accessing safe, stable housing, treatment resources, and a supportive network of alternative caretakers for their children. And these elements are oftentimes very crucial for meeting DCFS case plan requirements. I also think we have to think about the impact of incarceration on these communities. So I come from Cleveland, Ohio, where there is a large Black community, and we have some of the worst racial disparities in the nation, especially when it comes to pregnancy. And 1 in 3 Black men and 1 in 18 Black women will experience incarceration during their lifetimes. And a lot of those incarcerations are related to drug crimes. And so what you end up seeing is that you may not even, so you may have a child, you're a person who maybe used drugs when you were younger or lost your child to DCFS or went to jail. And now you have a child who is having a child, right? And if that grandchild of yours needs a kinship guardian because their own parent is not deemed fit for parenting, because of your history, you're often unable to become that kinship guardian, even though you're perfectly competent to do so. And so then you end up seeing these children enter the foster care system. Now, there are opportunities for improvement. So let's just talk about generally good medical practice. Uh-oh.
Hi there. Can others hear me audio wise?
I can hear you. This is Dr. Rhodes.
Okay. I don't know if there's any other kind of hearing besides audio, but you have to ask these days. Apps can do amusing things. I'm hopeful Dr. Zhao will connect back shortly. Oh, there we are. Hi, Dr. Zhao. believe you're muted.
I'm sorry. I think my computer wanted to die on me because I forgot to plug it in.
Oh,
Apologies.
well, I believe we were going to start talking about good medical approaches,
Yes.
but
Okay.
do we,
Sorry about
we
that,
help
guys.
by bringing up any slides on our side?
Can you still my screen still, or did I exit screen sharing?
We no longer see screen
Okay,
share.
let me go back to that. I apologize. Hmm.
There we are, back to good medical practice.
Sorry. You can't have a Zoom meeting without at least one malfunction. I
It has
apologize.
to happen one time, yeah.
Sorry. So, some generally good practice, I would say, for people in the psychiatry world is practice precise counseling. So, um, please be mindful of the way your words are interpreted by women who are already scared, typically, of using medications during pregnancy. So for example, just the other day, I had a lady who, was convinced that she had come off of her Lamictal for pregnancy because, her APRN told her that it could be increased risk of neural tube defects, right? That's not, I know this nurse practitioner, that's not what she said, but like that's how the patient interpreted it. And so I think it's really, in my practice, to try and be really precise as much as possible when I'm talking about risks associated with medication. So, I try and talk whenever the data is possible in terms of absolute risks, and to also make sure I'm talking about the flip side of lack of treatment. Right. So if there is, for example, a risk of neonatal opioid withdrawal when you're using MOUD, talk about, what level of risk are we talking about? Is the baby going to die? Are you going to be reported DCFS for that? Or is it something that's pretty easily treatable? And, and what is the risk of you not using your MOUD? I think that's really, really important. And then also I try and remind patients a little bit, sometimes people self-wean their medications because they're under the impression the medicines are dangerous, again, because of the way it was counseled to them. And it does not look good for them in DCFS investigations that they have stopped their prescribed medications typically. So I try and include that too. I also think it's important to try and properly document. And I think this is where practices might differ culturally. Some psychiatrists I know barely document anything because of privacy concerns. Others are much more verbose with their documentation. I think this becomes an issue for your patients who are kind of on atypical regimens. So, for example, they are using cannabis, and that's something that you think, given the pros and cons, like that's something they could remain on for like anxiety or whatever. Or if they're, particularly I see this issue a lot with people on high dose benzos. They just for whatever reason gotten on benzos for their treatment of anxiety, and who knows, maybe they're having trouble coming off of it. I think it's really important to document if you think they have a substance use disorder. And also what your intended plan is, right? Because it's a very different patient who just, I had a patient the other day who came from Jordan, and she was like, all they ever give you in Jordan for anxiety is benzodiazepine. So I'm on like 4 milligrams to 5 milligrams of Klonopin a day. She doesn't have a substance use disorder, but I think if you don't document that, then people are like, wow, like this lady, something is up with her, And so I think just be really clear with your documentation, and also if you're, want them to wean or not. Sometimes, I don't know, you guys use Epic. Sometimes people just have these smart phrases, and there's very little assessment written out. And it'll just say like what meds they're on, for example. And I do think it's important when you're talking about pregnant people on these atypical regimens, like document. Are they supposed to be weaning off their benzos, for example? How fast? How slow? Is it okay if they don't, etc.? I think that's important because other people are scrutinizing these women and they are looking at their charts. I also think it's important to continue to treat comorbid conditions. Hopefully this is very obvious to all of you guys, but a lot of women, when they get pregnant, they just get all their psych meds stopped. And that is not the appropriate treatment for pregnant women. Or, people with ADHD get taken off of their stimulants. That's probably not the best thing to do for someone who really needs those medications. I'd also maintain a really high threshold for treatment termination if you're able to. Sometimes there's policies at institutions that prevent you from doing that, but treatment termination is really not benign. It can be very hard for pregnant people with psychiatric disorders to find a new provider, at least where I'm at. And so I would really just try and maintain a high threshold for terminating your therapeutic relationship with these patients. And then finally, I would use biologic testing judiciously. You know, in psychiatry, I do a lot of urine drug screens because I do it for treatment monitoring. But I do try and be mindful of why I'm doing it, and also maybe what's the least invasive and legally complicated way I can order something. If you just want to know if someone is taking their Adderall because they're saying they're not getting any better and you feel like they should be based on the dose you're prescribing, you could just test them for amphetamines, But if you order just a reflex urine drug screen, it comes back positive for marijuana, and that is something that's reportable in your state, even though you don't think it's a big deal at all, that can have implications for your patients. Now, I'll just spend a few minutes talking about urine drug screens because they're kind of a big deal. Urine drug screens are usually there's very few pieces of data in psychiatry that DCFS has access to, and urine drug screens are one of them. And I think because of that, they kind of get like an outsized importance sometimes in DCFS investigations. And so, urine drug screens and other biologic testing is oftentimes misinterpreted by non-medical providers and sometimes even by medical providers. I've had caseworkers ask me if it's possible for the fentanyl in someone's urine to be from their epidural. And yeah, it absolutely could be if you are at an institution that uses fentanyl-containing epidurals. I've had judges express shock that you can have a urine THC level over 500 and not be intoxicated. I mean, of course, we all know that's true. I mean, urine is far removed from, your active intoxication. We've had DCFS referrals for women who were simply using their labetalol because they had a false positive meth screen and no one sent a confirmatory or asked what else she was taking. I have doctors who still don't think it's possible to have a positive opioid screen from eating poppy seeds or Russian tea cakes. So I just think, be really mindful of how you are using your drug screens in your practice. As once that data is out there, it's out there for people to do with it whatever they want. So just some thoughts to ask yourself about biologic testing. What is your hospital policy? When do you decide to order drug testing? Do you guys do confirmatory testing? Do you have an informed consent process? And, what are the reporting requirements at your hospital? In these days of shared EMRs, sometimes what you think is just between you and the patient is no longer just between you and the patient. And then finally, I would encourage collaboration. Do you have a go-to social worker that's kind of the expert in these policies who could counsel women about what working with DCFS is like? Do you have a contact at DCFS so that they feel comfortable asking you questions about, things that may come up like, hey, is it okay for this patient to be on gabapentin or Adderall or whatever, even though she's in recovery? Do you guys have a task force of some sort for women with substance use disorders, that maybe can make up more humane and medically sound policies as regarding breastfeeding, visitation policies, et cetera? And some institutions across the country, once a patient has a DCFS referral, I mean, and there's some thought that their baby might be removed, they can't even go visit their babies anymore. It's very, very sad. So it's not at all humane. And just so you know, once the DCFS removes your baby from your home, at least in Ohio, the typical amount of time you get to spend with your baby is 2 hours a week. And that is just awful for the mother-baby triad. So, sometimes to the extent that we can cross-educate and improve things for these women, such a big difference. I think specialty clinics are really great. And there are multiple examples of specialty clinics for pregnant women with substance use disorders across the nation. So ours is called the RISE program. I think you guys have one too. I was just looking on the internet. It looks like you guys have one called HEAL, which is like an IOP for pregnant patients with substance use disorders. It looks amazing. But whatever program you can create at your institution, I think it's going to be an improvement because patients have face so much stigma in their lives about their substance use and so much medical trauma that it's really relieving for them to know that they can go to a team with kind of this specialty knowledge who can understand their journey and they can treat them with respect and dignity. Plus, a lot of times when you establish these programs, they tend to scale up knowledge across the system, right, for other providers because they can see your notes, they can see how you approach various scenarios, and they can be training sites for learners. So I think they're wonderful. These are just some outcomes from our clinic. This is data from September 2021 to December 2022. And so, I think, and this is true, I think, for most clinics, the outcomes are superior. There tends to be a higher rate of pharmacotherapy use that's appropriate. They tend to be more engaged in behavioral services by delivery. They tend to go to their moms at time of discharge, which is really wonderful. And then our program also has a pediatric component because unfortunately, sometimes babies do not stay with their bio parents for safety reasons. But by tying in peds together, we can make sure that that baby is still getting some level of continuity with the medical team. And also it gives us a window of insight into how the bio parents are doing based on reports from the grandparents or, guardians. So for all of us who work in this field, there's a lot of ongoing work that we're always trying to do. Education is a big part of it because the more people know, the more we can have a common language and think about what's really best for these patients. Advocacy, always part of our work. And then just really trying to empower the patient to be part of creating better systems for parents with substance use disorder. These are some of the takeaways for me that I learned in the course of my work. So most people have a very limited understanding of substance use disorders and the harms of substance use, what it does and what it doesn't do, and the way the child welfare system operates. Hopefully this talk is giving you a little bit more insight into that. There are biases within the medical legal system that can harm families, even if our intent is to protect them. And this effect is magnified for families of color. And then finally, you really matter. How you approach treatment, how you document, how you consciously advocate and support these patients, it really does make a big difference for them. And I would encourage you to continue to be your patient's advocate because that's really our obligation as medical providers. These are some of the references I've used. I'm happy to share more. And I think that's it.
Well, thank you very much, Dr. Zhao. I invite anybody who is capable to come onto camera. And if you have any questions, I believe we do have time for that if you do, Dr. Zhao.
Oh, yeah, I'm good.
All right, excellent.
Sharing.
I know you gave us a lot to reflect on, especially with starting with the case. And as you were asking those questions, not only did I find myself without clear answers, I also found myself reflecting on the idea that I didn't even realize I should be asking these questions to start with. And I felt as though I needed to go back to residency just to learn all of these things. And this is the thing that I guess I mean in terms of feedback, which is I felt like I received a full residency's worth of education inside of the hour that you've given us so far. So I really appreciate all of the really wonderful information you shared.
You're too kind. And I would say those questions, it took me several years to answer them myself, Yeah,
and I think it brings up lots of nice elements, particularly this aspect of all of the extra administrative and legal issues that arise when it comes to providing safe and appropriate care. And especially at a time where we're seeing so many new laws enacted and new policies come up. I know for ourselves in the state of Arizona that this year goes into the record as the year where the most mental health bills have been
Wow.
at least approved or passed. And it's just so much information in terms of what's coming up that it's hard, I think, to stay both informed and up to date. So I wonder if you might have some thoughts about, well, what are good approaches when the political climate or the policies may be changing so quickly.
Yeah, I mean, I think it's such a challenge because, we don't act in isolation. When new policies change, I may have my own idea of what I want to do, but I still have to take direction from legal and, from the hospital administration. And so I think if you're interested in, especially advocacy, one of the best things you can do is try to be at the table, when people are making decisions. So, for example, we are currently debating how do we want to approach marijuana use in parents. I think PED still wants to know. They're worried about the medically vulnerable babies who marijuana, exposure could be harmful for them. They want to know if the moms can give their breast milk. On the other hand, I think the OB side, we're very sick of having to report women for using marijuana, so being at the table, talking with legal, maybe, seeing what other hospital systems are doing, like that's been a big part of our conversations. But it's definitely, we will, as people who are board certified and working within systems, we will always have to interact with the societal piece of our medical practice.
Hmm. To that end, I know that you had said, well, a common error that comes up when it comes to policy is related to then just shifting to reporting and referral, and that's kind of that immediate approach without emphasis on other things like resource education. And
Yep.
I wonder if, say, coming to the table, what we might consider, even if we're looking at other substances, and how a different approach has maybe been had, things like warning labels on the side of nicotine products and cigarettes,
Mm-hmm.
similar warnings happening for alcohol. I wonder if
Mm-hmm.
that's been anything that you've seen, or if there's been any push for something that's
Yeah.
more out front, preventative and educational, rather than that more punitive side.
Yeah. I mean, I think one thing, I don't know how you guys feel about the fact that marijuana was legalized in your state.
Mixed feelings.
I
Always
think
mixed
most people
feelings.
in the medical world have mixed feelings towards that, but I do think one positive is that it does allow us to have more nuanced and really medically focused conversations with people about substance use, because they're less afraid that it's going to have legal ramifications. They've studied, for example, things like medical, like marijuana warning labels. They'll have like a picture of like a pregnant fetus and be like X, harmful. And the studies are interesting because it kind of showed that for people who were already kind of planning to use those substances, they kind of just ignored them. They were like, whatever, like this is just, a thing you're putting on there to scare me, like a conspiracy. And it really made me like that study made me think like, like, people come into their substance use, I think, with pretty strong beliefs of what substances do or don't do for them. And I think the way to make changes in a medical provider is just to have that like respectful two-way conversation. What is this? What's the appeal of this for you? Like, are there things you're worried about? Are you open to hearing more? And I've definitely had people who made subtle changes in their framework about using drugs once we were able to talk really in more detail and in sort of like a non-threatening way about their substances. I think that definitely works. I also think, a lot of my patients use substances they are using to cope with other issues in their lives, right? So I don't know what the world of psychiatry is like, because I work in the OB-GYN department mostly, but we have made social needs screening a really important part of our clinic. So we basically do like a social needs inventory for all of our new patients, and we have infrastructure, luckily, within our resident clinic to address some of the social needs. I think that's really important. That's not traditionally medical care, and I think there's a great deal of room for collaboration with community services, but you can't like address major health issues. It's like diabetes. Like you can't expect someone to take their insulin if they don't even have a fridge to like store it in. So I think similar issues are happening in psychiatry as well.
Certainly. And I think these are really great reminders about practical inroads that we have and opportunities where we can make a notable difference for persons. So I'm not seeing any discrete questions in the chat. I am seeing plenty of praise and appreciation. So thank you again for speaking and meeting with us today. Really appreciate it.
Absolutely. Thank you guys, and hope you have a great week. Bye.